Hello, my name is Natalie Phillips. I'm a Lymphoedema Clinical Nurse Specialist from the UK, and today I'm going to spend a few minutes talking to you about the importance of understanding the link between the veins and the lymphatics in lower limb conditions. It's important to recognise venous disease early, and through this session we'll discuss the impact of the lymphatic system and recognising its involvement in venous disease, what edema signifies, and the complications if it's not treated early enough. So the focus is on early intervention and long-term management. In a healthy state, oxygenated blood is pumped from the heart via the arteries to the capillary bed. At this point, plasma leaks out into the interstitial space by capillary filtration, providing oxygen and nutrients such as large protein molecules to the cells. Once fluid leaves the capillaries to bathe the tissue bed, it returns to the circulation via the lymphatic system. This interstitial fluid is full of cellular debris and bacteria, which then drains into the initial lymphatic system. The initial lymphatic system is held in place by anchoring filaments which attach to the skin, muscles and surrounding tissues, and they only open in response to changes in tissue pressure or movement. At this point, fluid enters the lymphatic system and is then known as lymph. It is transported through the lymphatic system, so through its pre-collecting vessels, into its deeper collecting vessels, and then onto the lymph nodes. When in the lymph node, the lymph is filtered and becomes more concentrated, as part of it will return to the venous system at this point. The remaining concentrated lymph is then transported into the major large lymphatic truncal vessels and transported back towards the heart, where the remainder is drained back into the blood circulatory system. Evidence suggests that the difference between the interstitial and venous pressure was too low to promote reabsorption back into the veins, and it is now believed that 100% of liquid within the tissues is removed via the lymphatic system. So it's really important to remember this, and it's really important to recognise problems as early as possible. So if a patient presents with spider veins or varicose veins or intermittent edema, this should be treated. When the vessel becomes varicosed, the valves within the vein are unable to propel back towards the heart. This leads to a backflow and venous hypertension, where you have plasma from the blood leaking back out into the tissues. Over time, this will manifest and you will see changes in skin colour called hemosiderin staining. Skin changes will occur where the skin can become firm and fibrosed. A wound may develop and patients may report pain. Chronic edema often occurs as a result of inflammatory processes such as cellulitis or other chronic skin conditions, which result in excess fluid production and is very more commonly seen in chronic venous insufficiency or secondary to chronic venous insufficiency. So where the fluid is leaked back into the tissues, the lymphatic system starts to become overwhelmed. This is often diagnosed when a patient has had swelling for 12 weeks or more. And in this case, there is an imbalance between the amount of interstitial fluid in the tissues and the rate of uptake back into the venous system. Furthermore, this puts patients at risk of developing cellulitis, as well as cellulitis itself being a precursor for lymphatic problems and further damage of the lymphatic system. Many patients who develop cellulitis and are not treated early enough, or not treated with gold standard compression therapy, go on to have repeated episodes of cellulitis and quite often hospital admissions, which result in a burden upon our health service. So again, early identification and treatment is paramount for for this group of patients. We quite often see patients who have extensive skin changes that may develop varicose eczema, hyperkeratosis, where you get build-up of plaques of skin on the limbs, as well as wounds and infection. So when we are assessing for this, it is important to think about how we use the CEAP classification for venous disease. So the clinical, etiological, anatomical, pathophysiological classification that was created in 1994 and has been modified since was used to standardise the diverse manifestations of chronic venous disease. It's a table and a classification system that has several different symptoms listed, from no visible or palpable signs of venous disease right up the trajectory to active venous ulcers. And within that, we have the symptom of edema. So relating edema to venous disease can be done using this system, and it also allows us to realise that when edema becomes present, the lymphatic system is becoming overwhelmed and is not able to drain fluid from the tissues as it normally would. In lymphedema, we relate this to the ISL stages for lymphedema, which again is a classification system that allows us to look at symptoms from no clinical or no signs of evidence of edema to early onset to persistent swelling that has marked skin changes and tissue changes. And it allows us to also think about, we have to recognise the role that inflammation is playing in both of these symptoms where you have venous disease and chronic edema. Inflammation is part of the complex biological response of the body's tissues to harmful stimuli. It causes an increase in the prolonged production of immune active cells, cells responsible for repair and removal of bacteria, cell debris, and overexpression of these leads to skin changes. So again, where patients have skin changes such as thickening, fibrosis, in the presence of edema, it is quite often as a result of inflammation. Chronic edema occurs often as a result of an anti-inflammatory process, such as cellulitis or other chronic skin conditions. Again, where patients may have venous insufficiency, systemic failure, renal disease, and where we have obesity. Obstruction of the lymphatic system does also result in reduced drainage of interstitial fluid, resulting in an increase of fluid in the interstitial space. So if not removed, the fluid within the tissue space stagnates and causes this prolonged inflammatory reaction. As a result, macrophages will start to release inflammatory molecules, which in turn leads to cellular damage and fibrosis, scarring and thickening of connective tissue. This also predisposes the patient to cellulitis and wounds. So it's clear that there is a link between the venous system and the lymphatic system, but how do we manage it? So gold standard throughout the globe, there are treatments that involve surgery for venous disease, so vein stripping and surgery such as that, and then there is gold standard using compression therapy. And we know that especially in chronic edema, that if patients are treated effectively with compression therapy, that it reduces the incidence of cellulitis, which also reduces the burden on our health services from patients being taken into hospital. Furthermore, using compression therapy is well documented in venous disease, so having active compression therapy or graduated compression therapy can prevent venous leg ulcers from reoccurring. This is often put in place with combinations such as skincare, exercise, diet and lymphatic drainage, but all of these help to reduce the risks associated with chronic venous insufficiency. Furthermore, it's important to understand, yes, there is that clear link between venous and lymphatic systems. Where the venous system starts to fail, then this will instantly put a strain on the lymphatic system. So it's important to treat venous problems early. We've said that it is well documented the complications and long-term health effects that venous disease can have on a person, including a huge impact on quality of life. The burdens of wound care and chronic edema on healthcare and on healthcare systems is increasing, so our emphasis has to be placed on prevention being better than cure. Thank you.